lot of mistakes are made in healthcare, and you just don't know about it. And I believe that the human, the patient, the consumer, is the ultimate arbiter of their data and the person that cares the most about it. And we've had years of portals and low adoption of them because they don't work well. We need to plug patients into the networks that the providers are already plugged into.
We are losing healthcare workers because of the burden of what they had to go through. And we all understand why. But this doesn't mean you have to give up your passion of serving people, right? And caring about people. So in this area of informatics, public health informatics, these are the most valuable people to really learn what data is necessary to understand better the community needs.
Certainly understanding how clinicians, doctors, nurses, MAs, I mean, they carry the workload of the health and safety of this country on their backs, and especially as we've seen during COVID. And so you get inspired by that, and yet you also see all their manual processes and their laborious, kind of level of efforts where digital and technology automation does not help them.
Look, innovation happens every day, and the fact that we are forced to be at home, it didn't mean that we had to stop innovating. And as an educator, I couldn't be more excited about the needs of better education, better training, better research, so we can help our communities.
I don't believe that healthcare has experienced network effect. I don't believe that the magic of multiple entities making a network stronger and seeing order of magnitude more value for their efforts by virtue of their connection to others kicking in yet. It's all kind of a top-down, sort of waterfall type approach to management and care delivery.
Like everyone says, well, the reason that you can't have transparency and prior auth is because we really don't know what it's ultimately going to cost. Well, when you get an airplane, they don't really know how much it's going to cost you to land that plane because they might be using more jet fuel flying around because there's a tornado, right? Yeah. We just can build that into the risk model, into the pricing model. We can do that with more data. We can be smarter about this, and we can overcome any objection to do this better.
This creates a massive hive of information that can be shared across the continuum. And again, back to my point about high acute populations, these are the people everybody wants to see. When you hear readmissions, they're focused on this population. Oh, yeah. When you hear about length of stay, these are the folks that they're trying to make sure we have an appropriate utilization level.
And while we might not think that prior authorizations are a part of this world we call interoperability, but they very much are, because you are disrupting that continuity of care when a patient's at the glass at the pharmacy waiting to get their prescription and it hasn't been authorized because some sort of step therapy had to happen, and the patient's like, well, wait a minute, I can't get it. Oh yeah, come back tomorrow, we'll get your prior authorization, and they don't go back, they don't comply. Or you end up with a prior authorization that's got some really critical information in it.
What I think established providers are going to struggle with is if somebody's an omnichannel patient, if somebody is touching care both in and outside of their kind of data moat, can they handle them properly with the current technology environment, or do they need to refer to some sort of system of patient's record?
If the connection is in place and a patient is headed my way into my skilled nursing home, I can go into an inbound tab in PointClick Care, and when I click on your name, John, I can see all the documentation that the hospital actually recorded for you. The history and physical, the speech information, all of your therapy notes, all of your medications, all of that with a single click, I can pull it in, and
Full handoff.
Yeah, it cuts the admission time down from an hour and a half to about 15 to 20 minutes.
Because one thing that we do have is 4 to 10x higher adoption when it's that doctor recommending something to a patient than the employer recommending something to their employee base, or the payer even like suggesting, like, John, you really need to manage this, and people don't trust insurance. Why are you trying to get me to do this? But if the doctor says that, people will more readily accept and adhere, especially when they know that clinician is looking over their shoulder at the data stemming from that app or tool or program to know if the patient is being adherent to that.
Get them digital. We have to get people digital. Get them digital. Meet them where their maturity is. We get them on an electronic document, just like we did back in 2007, 8, and 9, getting physicians onto an electronic health record, the possibilities are endless because the intelligence in those documents now can be extrapolated so that you can do so much more with it.